Clinical reasoning is a subset of critical reasoning, which is the rational process of obtaining, interpreting and using knowledge and other factual information logically to make decisions and solve problems. Like critical reasoning is based on the logical application of clinical knowledge gained from experience, relevant academic research and information gathered from the patient, such as signs, symptoms and profile. The purpose of this is to generate a diagnosis, a prognosis and a treatment plan and progression of such treatment plans. It should be based on logical processing of information gathered and interpreted through the lens of the practitioner's experience and study. These are short definitions, so I'll read them out. I know you're capable of reading it, but I'll read them out and then I'll talk around them. So an illness script is not really a method of clinical reasoning. It's a description of the way the clinician thinks about the condition that the patient has. So it's essentially his idea of what a particular condition looks like clinically. And of course, the more experience that clinician has with the condition, the richer and broader that illness script will be. So it gets deeper and it gets wider, and it includes outliers and very atypical presentations and so on. So it makes it easy for the experienced clinician. I'm talking about a well educated and experienced clinician, not just somebody who's had a lot of years, but somebody who's given thought to what they're doing. It enables them to come up with differential diagnosis very easily when it's at all possible. So it doesn't explain, it's not of use when you're using clinical reasoning, but it does explain how your mind can work. When you're a new grad, that illness script is poorer, it's impoverished. What you've got there is information from books, it's from your teachers, a little bit of experience but not a lot, and certainly not a lot of independent experience where you really have time and training to be able to reflect on your practice. So you have to come up with other people's notions of what that condition is. Of course, your illness script will be determined to some extent by the type of patients you get in the practice you're in. If you're seeing athletes, you're going to see tennis elbow with a lot more variation than if you're not seeing athletes, for example. If you're dealing with industrial workers, then heavy injuries are going to be more common than if you were seeing children. So it's going to be dictated by your practice as much as anything else. The essential illness script, though, is essentially the minimum diagnostic criteria to make the average presentation of a condition vulnerable to your diagnosis, your clinical reasoning. So this is what you need to make that diagnosis, but it's the absolute minimum. So it stops you from taking more information than you need for that diagnosis, and you can focus on it. So you cut out everything that's not relevant to the diagnosis. It may be relevant to the staging, it may be relevant to the rehab and everything else, but to the diagnosis, most of this information is excessive and surplus. So, for example, if we look at, we're going to use this example all the time through because it's familiar, lateral elbow pain. If you're thinking of tennis elbow, common extensive tendinopathy, then the essential illness script for that is pain on the lateral side of the elbow, pain on gripping rather than moving the elbow, palpation tenderness over the common tendon, and isometric wrist extension being positive. Now, that's the minimal criteria that you need. And if you think about it, it's difficult to add anything to that that will make the diagnosis more complete. Staging is another issue. If you're looking between tendonitis and tendinosis, you need more information. But for the actual diagnosis of tendinopathy, that's pretty much all you need. Everything else about etiology, rehab and so on. But for the diagnosis, you really don't need much more than this. So it allows the inexperienced clinician to mimic pattern recognition, at least to the extent where they can make the diagnosis, even if they can't come up with reasonable differential diagnosis to test their diagnosis against. So the mantra for this really is, and it's the one I use all the time, is 4 questions, 2 tests and no more. You have to be prepared to change your hypothesis. You have to make the hypothesis on the first piece of information comes in, and it either gets stronger as more of the illness script comes in or it gets weaker. But you have to be prepared to change the hypothesis as soon as you get a better fit for the patient's signs and symptoms. So this is illness script and essential illness scripts. Over the next couple of slides, we're going to look at examples of essential illness scripts. On this slide are probably the most 2 common causes of low back pain you're going to come across in your entire career. They should swamp all others: stenosis, disc herniations, spondylolisthesis, pretty much everything else. This should be mostly what you're seeing, if you're in a manual therapy practice at least. What I've done for each one, the lumbar dysfunction and the sacroiliac joint dysfunction, is I've given the illness script, the essential illness script, the main outliers, and because there's a few of them, it looks like they're common. They're not particularly common. The average presentation is the one that occurs most averagely. I would say, given a couple of variations, it's probably going to make up 60 to 70 or maybe more percentage points of your biomechanical dysfunctions in the lumbar spine. But the main outliers are there, and if the essential illness script isn't working and it still sort of looks like a biomechanical dysfunction, then give some thought to the outliers. And then, of course, for each one, I've listed differential diagnoses. Now, this is personal. Some of these conditions have multiple differential diagnoses possible, others less so. Now, for a useful differential diagnosis for bias correction and for checking your diagnosis, again, for the most part, these look to be a good fit for your diagnosis and for the patient's signs and symptoms. Your diagnosis is the best fit, hopefully, but what you're doing is checking the fit of the differential diagnosis listed against yours and see if it really is the best fit. And you won't know until you actually start formally looking at these differential diagnoses. So it stops all the bias. It stops confirmation bias in particular, and anchoring as well. So it's well worth thinking about these. So I've listed differential diagnoses for each one. Now, I'm not going to go over these slides. You can read them perfectly well. And I'm going to leave it to you to either pause the video and I'll probably send out a PDF of this presentation so you can have these diagrams with you if you need them. The point I would make is, though, is that a patient comes with lumbar pain, low lumbar pain, and it's usually unilateral, so this could easily be the sacroiliac joint because it tends to spread over that area a little. So it could be the SI joint. So what you do is you make the diagnosis of a biomechanical dysfunction first, and then you separate the two out, lumbar dysfunctions versus sacroiliac joint dysfunctions. And you can do that with PAs over the lumbar spine, remembering though that PAs over the L5 will also effectively be a PA on the sacroiliac joint. So if it's particularly sensitive, you're going to get pains coming from that. But Fortin's tests, subjective and objective Fortin tests, are also usable to differentiate the two. And often both will be present, especially at L5S1. So essentially you can look at that as staging, if you like, but the initial diagnosis is biomechanical dysfunction. So I'm just going to let it run for a few seconds. I'll whistle or do something for you, no I won't, but then by all means pause it. Same type of diagram for headaches. So I've included the common one, which is coming referred from your neck, spondylogenic headache. But I've left out a lot of the information about outliers and so on. And I've concentrated on the essential illness scripts here. So we've got spondylogenic headaches, VVI headaches, migraines, and slow subdural bleeds. So I've included one rare one that is dangerous, very dangerous. Migraine, which can be caused by trauma, and it's well worth separating out. And obviously VVI you want to get rid of before you start playing around with the neck too much. So these are straightforward essential illness scripts on this slide. And you can work out the outliers as you go, and as you meet them, and also the differential diagnoses. You can give some thought to those and what else may mimic these conditions. Okay, another diagram. This one on disc herniations with and without radiculopathy. Not all disc herniations cause radiculopathy. So this is about uncontained disc herniation where the disc is bulging, whether it's either a prolapse or an extrusion or possibly a sequestration. But the disc is bulging significantly, and it's the compression of the structures it's bulging onto that for the most part causes the symptoms. Contained disc herniation, the pain itself comes from the disc itself rather than the sensitive structures around the disc. So if we look at the uncontained disc herniation, first without radiculopathy, the essential illness script is history of back pain prior to this, but not necessarily of this type. Just it's usually some history of back pain going back. The episodes are severe. These are catastrophes. So typically this is a unilateral severe, very severe back and leg pain. There are both flexion and extension functional impairments. The functional loss is obligate. They can't walk. The idea that this is worse on sitting and better with walking is just not true at all. These things are painful sitting, they're painful on walking. They get worse as you walk, and you cannot walk, you limp. There is a deformity, it's at least a kyphosis, usually a kyphorhodoscoliosis. All ranges of movement are affected. They're all limited, they're all painful, not necessarily symmetrically, but they're all affected. The dural test is positive. It's almost always a straight leg raise. The more positive the straight leg raise, the more specific it is for disc herniation, and a cross straight leg raise is pretty much specific for a disc herniation. Now, if there's no radiculopathy here, the pain will be somatic and not neuropathic. There's not too many conditions that could be mistaken for an uncontained disc herniation. First one is a contained disc herniation. This can give you back pain and leg pain. It's usually bilateral. One side is worse than the other one usually. Discitis will do the same thing as well. For whatever reason, infection, just degradation, for whatever reason, the disc becomes inflamed, and again the disc is painful. Sacroiliitis is severe pain, and this can look like a disc herniation as well. And also every now and then an atypical biomechanical dysfunction will be severe. It's usually the first episode, it's severe. So this isn't the hypothesis one. This would come from finding out that this isn't a disc herniation, probably because the straight leg raise isn't as severe with an anywhere near as severe with a biomechanical dysfunction as it will be with a contained disc herniation. It may actually be negative, as it may well be with a contained disc herniation and discitis. Essentially they will be negative. Now, you can have these without radiculopathy. More commonly, they're associated with a radiculopathy. So what you'll see with the radiculopathy is a segmental distribution of lancinating pain, paresthesia, hypoesthesia, paresis, hyporeflexia. It doesn't have to be all of these at all. Any one of these would argue that it is a radiculopathy. Certainly hard neurological signs such as sensory and motor loss would indicate radiculopathy, but lancinating pain, that neuropathic electric shooting pain, means that the nerve has been damaged. So this is pathognomic of a radiculopathy, at least a radiculopathy, if not multiple radiculopathies. Differentials include Caudery-Quiner syndrome, which is a multi-radiculopathy. It could be a plexopathy for whatever reason. A peripheral neuropathy could do this. Piriformis syndrome, for example, can look like a radiculopathy, and neurological diseases can mimic a radiculopathy as well. And then the rare ones like neuromas and so on can all do the same type of thing. A radiculopathy isn't necessarily caused by a disc herniation, but if you're seeing a radiculopathy that doesn't include severe back pain and severe leg pain, then the chances are this is of a neurological origin and not the musculoskeletal caused by a disc herniation. So these are four methods of clinical reasoning. Three of them are really quite common. First off, there's differential diagnosis. This is the method that House uses on the TV show, makes a list of differential diagnoses and then tries to prove each differential diagnosis. It's easier to do in medicine because you can aim lab tests at them and so on. You have to do the clinical examination first and list all these diagnoses, but you just throw more tests at them to see which one is positive. It's not very useful for us because we can't throw objective tests at them, so we have to make this based on the clinical exam. It's very cumbersome. What House does is usually treats it to see if it's going to work, almost kills the patient, brings them back from death, and then suddenly has an epiphany walking into an elevator or something. That's not very realistic, nor is it particularly the most effective way of going about things for us anyway. The way it's usually used is hypothetic inference or hypothetic abduction. This is also called hypothetic deduction, and it's a complete misnomer because if you're doing deductive reasoning, then it means that providing the premises are true, then the deduction must be true. That must be the correct solution to the problem. The problem you're dealing with, of course, is patient symptoms and your ability to test signs and interpret them. So the premises are not necessarily true. In fact, it's rare that all of the premises are true. So you can't deduce from this. Unless you're looking at pathonomic signs, which are very specific for that disease and only that disease, then hypothetic or deductive reasoning is not that valuable in clinical reasoning. But this is inference. This is inferring from the signs and symptoms. We'll talk about that in a second. Then there's script focus hypothetic inference or abduction. I've got this is a disclaimer. This is mine. What I've basically did was looked at the minimum diagnostic criteria for each condition, diagnosis, in my experience anyway, and I've used that as the reference point for the average condition. So this is a faster way of doing hypothetic inference, as you'll see in a second. And then there's finally pattern recognition, which is the domain of the reflective expert, the person who reflects on their practice constantly, learns constantly from mistakes and occasionally from successes, and has become able to recognize patterns very, very rapidly and almost always accurately. Generally, differential diagnosis is used to make a diagnosis. It's certainly not the only use of it. In fact, we're going to explore more useful uses of this than actually making the diagnosis for our patients at least. But it's basically making a list of diagnoses that could cause the symptoms of which the patient is complaining and then differentiate them to arrive at the correct diagnosis. Now, there's positive differential diagnosis where you use specific and sensitive tests to prove that diagnosis is true. And then more usefully, I think, there's negative differential diagnosis where you use highly sensitive tests when negative to refute that differential diagnosis. So you're left with the one remaining test. Now, to prove it, you need a whole bunch of tests. You need, if you look at an essential illness script, you need at least 2 tests, at least 4 questions, and sometimes it's more, depending on how coherent the patient is. To refute it, you just need one highly sensitive test that is negative. For example, I can say that the lateral elbow pain of the elbow joint isn't the problem because quadrant testing of the elbow is negative. And there is no condition of the elbow joint where you could have negative quadrant testing. It's just too sensitive. It's all pretty much 100% sensitive for elbow joint problems. So this is a much better use of it as far as I'm concerned than using positive differential diagnosis. But we'll look at that now. Okay, so this is an example of the process of positive differential diagnosis to make a diagnosis. So the patient comes in with lateral elbow pain. Now, if you think about it, the 4 obvious ones for lateral elbow pain will common extensive tendinopathy, incorrectly and misnamed lateral epicondylitis. There's no evidence that it's inflamed, and there's no evidence that the lateral epicondyle is in trouble. Arthropathy, arthritis or arthrosis, biomechanical dysfunctions, or it's referred from the shoulder or the neck. So these are your differential diagnoses underneath the label DDX. The essential illness script for each one of these, including the lateral elbow pain that we've been given, will be for the tendinopathy will be pain on hand use, gripping. The tendon will be tender on palpation. Isometric wrist extension will be positive, and that will tell you it's a tendinopathy. It's either a tendinitis or a tendinosis, and they're the variations, and you need to basically stage that condition. You really don't need much more than that. You do have to know about etiology, you do have to know about whether it's inflamed or degenerate, and you do have to know about occupation and so on to retrain them. But for the diagnosis, that's pretty much all you need. Now, for an arthropathy, the range of movement is going to be limited. That's going to be variable according to which joint is inflamed, or if they're all inflamed. And you're going to see different patterns of restriction. But the two ends of range here will be inflamed. The pain will be asymmetrical because one end of range is moving towards the closed pack, one is not. So that will be much more painful when you stress the joint more with the closed packing. And you'll either have a spasm or a hard capsular infill, depending on whether it's inflamed or not. So again, your variables are arthritis or arthrosis, ulnar humeral, radio ulnar, or all three, or two of those three. Biomechanical dysfunction, you're going to see episodic, moderate pain, impairment, unidirectionally dominated. That is, if you're looking at flexion extension, for example, either flexion or extension is going to be functionally dominant. They may well have a lot of trouble getting their elbow extended, but on flexion, for example, that may be somewhat painful, but much fuller range, but it's dominated by the loss of extension. It just depends on what movements that joint is capable of as to the actual directions. You're either going to have a jammed infill if it's a subluxation, a pathomechanical subluxation, or a soft capsular infill if it's hypermobility, or it can be a hypomobility caused by basically an arthropathy again. The range of movement will be limited with a jammed infill anyway, unidirectionally. With a hypermobility with a soft capsular infill, it depends on the movement that's painful. If only one of these movements is painful, then it will only be limited in one direction. If both movements are painful, then it will be limited in both, and usually it's one direction. This biomechanical dysfunction is usually a subluxation. It's usually a pathomechanical hypomobility that gives you the episodic pain and so on. So it usually is the jammed infill. Referred pain, what you're going to find here is there's no hard local signs. There may be neurophysiological signs because of nociception, reflex inhibition and so on, but that you can get rid of these by basically inputting proprioception, wobbling the joint, and those soft signs will go away. That's usually weakness and tone changes. But you're not going to see abnormal hard local signs that don't disappear with simple wobbling. With referred pain, it's usually only an aching pain. Very rarely is it a sharp pain on movement. It usually follows on from overactivity of the referring area, and you will find signs and symptoms remote from the lateral elbow in the referring area, and variably that could be the shoulder or the neck, reflecting pain down. Hypothetic inference or inferential reasoning. It's also called abduction. Abduction means taking away, which is the literal meaning here. You're taking away inferences from the information you have. It's just confusing for us. Every time I've used abduction, immediately the shoulder springs to mind of the student. So inference is a better term for this. It is by far the most clinical, the most common method for arriving at a diagnosis, and it should also be the most common method for arriving at a treatment plan as well. So essentially what you do is you accumulate information from the patient, that's the signs and symptoms, and about the patient in the patient profile. This is mixed in with your experience and other knowledge of pathology, anatomy, the other clinical sciences, biomechanics and so on, and you will be able to generate the most likely explanation for their presence. However, this isn't deductive reasoning, so there's always a degree of doubt about the conclusion that you reach. And this is why it's not deduction, because the premises are not always 100% true, and so your conclusion must be probable rather than true, if that makes any sense to you. Okay, so this is generally the way you're taught hypothetic inference in the schools. That is, you ask as many questions as you can think of, and then you sort your way through them and come up with a diagnosis. So it looks something like this. Patient profile, the gender, age, body type, activities, occupation, relevant history, both medical and previous physiotherapy history, and so on. Subjective exam, you're looking for the exact location of the pain, the number of symptoms the patient has, the quality of those symptoms, the intensity of those symptoms. Is the problem episodic or is this a one-off? What's it like in the morning? What's it like at night? What makes it worse? What makes it better? Any other behaviours that will affect the symptoms, or any other symptoms that hasn't been already mentioned. Have you noticed any swelling at any time? When was it? Is it recurrent? Do you see any discoloration at all? Tenderness when you prod and poke, does it hurt you when you do it? And also any skin changes, rashes and so on, edema. So probably you was given more than that, but these are the ones that come to mind immediately. And then objective testing, the selective tissue tension test, active, passive, resisted stress test, and so on. Any special tests you might think to do. So if we're looking at the elbow, you would do active, passive, and resisted flexion, extension, pronation, and supination. You would stress test those ligaments. You would look at the end fields on the active movements. And you would resist those movements as well. You would do neurological testing around it, and that's it. On top of which, you may or may not have special tests in the elbow. You might be looking at Tinel's test, cubital tunnel syndrome tests, and so on. These tests will be indicated because of the history or because what you found in the routine selective tissue tension test. You take all those three things together and you make the diagnosis. This is probably the way you've been taught to do it. On conditions that you know well, like lateral elbow pain, you probably don't do all this. You cut this way back to the essential illness script or your version of it, and you are now mimicking the expert because you pretty much are an expert in tennis elbow. But this is the way that in general you've been taught to look at hypothetic inference, if it was called that. Third method on our list, script focused hypothetic inference, SFHI. This is hypothetic inference but minimized. And as I said, what I've done here is I've looked at the minimum diagnostic criteria, the minimum number of signs and symptoms that will pretty much diagnose that condition, and not bring in anything else that pertains to treatment, etiology, or anything else that can all come after you've made the diagnosis. In fact, it really has to. You can't look for an etiology of a condition when you don't know what that condition is. It should be mixed together. We are not good at multiple tasking. We're just not. Even women, I'm afraid. We're just not very good at it. And what it means is, while you can do it, each task gets done more poorly than if you'd done it on its own. So focus on what you're doing at the time. It doesn't actually save you time, because you flip backwards and forwards between your tasks. You don't do two things at once. You flip backwards and forwards. This is what the research has shown. So we don't worry too much about their profile, except for the male, female, So if we think about back pain being caused by prostate cancer, it's obviously then it becomes an issue. And you don't look at information that's not specific to that condition. So this reduces bias and error by reducing how much information you have to take in. The error comes when you get overwhelmed by the amount of information. And this is the most common complaint when you're using hypothetic inference uncontrollably the way you've probably been taught to do it. Just ask every single question, do every single test you can think of, and then see what turns out. You end up with way too much information, it's overwhelming, and what you do is you grab onto the first piece of information that makes any sense and you cling to it. This is called anchoring. You do not let it go. This reduces that. If you use bias and error correction as an integral part of script focus hypothetic inference, which is what I intend, then you automatically reduce bias and error during this process. If you have to change your hypothesis once or twice to get a better fit with the new information coming in, then you're reducing availability bias. In fact, you're eliminating availability bias, and you've eliminated confirmation bias, the two biggest ones out there. So this will reduce bias and error. It takes the stress off you from asking every single question you think about. More importantly, it takes the overwhelming nature of all this information, leading you to anchor onto something familiar. So my suggestion is this is a good substitute for clinical reasoning, for pattern recognition, until you can get to pattern recognition. And I believe this will help you do it because you're constantly thinking about the criteria required to make that diagnosis. This is not like treatment classification where you simply lock in the piece of information into a little box and see if it fits, and then out pops the treatment. For one thing, it leaves you vulnerable to outliers and even slight variations of that condition, and nobody is the same as everybody else. Everybody is an individual. Their presentations are going to slightly vary, and depending on how many categories you're trying to fit these people in, they may not fit any category. Plus the fact that does not prepare you for clinical reasoning in the least. You're relying on the ability of the person who constructed that classification scheme to have no biases, to make no errors, and to be correct in what they're saying. Whereas with some experience and so on, you could draw up your own essential illness scripts and be happy that they are personalised to you. Meanwhile, I've supplied some that you can work with. This is a general outline of how script-focused hypothetic inference comes about. We start off with the illness script, and it depends on, as I say, your experience, your expertise, how rich that illness script is. From that, you make the essential illness script, the minimum diagnostic criterion that you need to make that diagnosis. This will take you to script-focused hypothetic inference. That is, you get the first symptoms, you generate a hypothesis, and you immediately test it with the illness script that you choose. And this can be the one that it's not likely to be, so you can run through some different hypotheses and know that you've eliminated bias, or it can be the one that you like and then you have to worry about bias later on. It's entirely up to you, providing you're prepared to change the hypothesis when it doesn't fit as well with the new information. So you may make one hypothesis, you may make 10 hypotheses. Usually 2 or 3 is enough, but it's 1 through n. Once you've made that hypothesis and you've proven the hypothesis, before it can become the diagnosis, you have to refine the stage if it's necessary. Is it tendinitis, arthritis, tendinitis. Once you've done that, then you attack it with bias and error correction. Mostly it's differential diagnosis, but you may have to complete the exam to reduce the bias from premature closure. Oh, I know what it is. That's as much as I need to do. So between the differentials and, if you need to, the full exam for premature closure, you can now say that you have a working diagnosis. The hypothesis now equals the working diagnosis, and that is what you're going to plan treatment with. So you treat them according to that. If the treatment works, or at least if the treatment works out the way you expect it to work out, even if it doesn't work and you're just trying to see what's going to happen, then your hypothesis works and you now have the diagnosis. It may not be, but operationally that's a diagnosis. The hypothesis led to an effective treatment, and operationally that's as good as having the diagnosis. If the treatment doesn't work, either the working diagnosis is wrong or you're doing bad treatments. Either way, you have to basically revisit the diagnosis and your treatments and see which one is likely to be wrong. That's the general outline of the process. So the way this may work with lateral elbow pain. I've got pain over the lateral elbow. I make the first hypothesis. In this case, rather than do the obvious one, which is common extensive tendinopathy, I'm going with a biomechanical dysfunction, but it could be any of the other differentials. So I then apply the essential script of biomechanical dysfunctions to the hypothesis. If it fits, then what we have here is fitting. We then attack it with bias and error correction. If that is good, then we have the hypothesis equaling the diagnosis as a working diagnosis anyway, and that has to be confirmed by a successful treatment. If the bias error correction is bad, then we need a new hypothesis. Similarly, if the essential illness script did not fit, we need that new hypothesis as well. So we have H2 based on where the pain is and the new information coming in when we were seeing if the essential illness script for the biomechanical dysfunction worked or not. If it doesn't, we have that new information, and we should be able to come up with a better fit. For example, if I'm thinking it's a biomechanical dysfunction, I'll look at range of motion, and if the range of motion is good, then I'll get rid of the biomechanical dysfunction as a possibility, move on to H2, which in this case is common extensive tendinopathy, but it could be anything else you like. It could be referred pain, but we're going to go with common extensive tendinopathy. And again, if that EIS fits, then we attack it with bias and error correction. If that's good, then we have H2 equaling the diagnosis, and then we move on to staging. If the EIS doesn't fit, then we need H3, and that works out the same way. If it fits, H3 becomes a diagnosis. If it doesn't, we move on to H4 through HN until we come to one that works. If none of them work, then somehow or another this is going wrong. So you need to start all over again. If you still can't figure it out, that's when you ask for a second opinion. Or you can take the most probable one it is, do a trial treatment, see if that works, and then if it doesn't, then you're a bit out of luck and you're going to have to get some help with it. So everything is trial and error. You try the hypothesis, you see if it fits. If it doesn't, you try another hypothesis, you see if that fits. If you get one that does fit, then you aim the treatment at it, and if the treatment works, then you're good, and if the treatment doesn't work, then you're not. Trial and error. This is a number of different experiments. Basically, you're using the scientific method here. Up until very recently, I've been using script-focused hypothetic inference as what I teach as the main method of clinical reasoning for diagnosis. Very recently, though, I've been giving thought to combining both negative differential diagnosis and script-focused hypothetic inference. And I think this actually works better because you can get the bias and error correction out of the way up front, and also get to your first hypothesis that much more quickly, rather than picking one at random. So I think this will certainly reduce availability and confirmation bias, and I think this is quite a useful thing to do. It's well worth trying anyway. So we're coming back to, again, lateral elbow pain, which we've been using all the way through this. and we're going to apply negative differential diagnosis. So our 4 differentials are going to be the same as they were before: common expensive tendinosis, elbow arthropathy, biomechanical dysfunction, and referred pain. But now we're going to use highly sensitive tests for each one of those to basically eliminate each one until we can't eliminate it. So for common extensive tendinopathy, the sensitive test is palpation. We can palpate the entire length of that tendon and the musculoskeletal junction, and it's difficult to envisage how you can have a tendinopathy and not have the tendon tender. So if it's negative, we've just got rid of common extensive tendinosis. Elbow arthropathy, quadrant testing, and with biomechanical diagnosis, this is also quadrant testing. It's just that the pattern of the quadrants will be a little different, but it's telling you there's a problem in the elbow joint. And then for referred pain, palpation, quadrant testing will all be negative. Your isometric tests will be negative there. All local testing will be negative, and you'll find signs and symptoms in either the shoulder or the neck in this area. So what you're left with is probably only one of these differentials still standing at the end of this. So if you look at the EIS for that, which we now use to attack that differential diagnosis, if you look at the EIS for common extensive tendinopathy, palpation, it's going to be positive. There's pain on hand use, isometric wrist extension is positive, fairly definitive. For arthropathy, that is arthritis, arthrosis now, you'll have 2 or more quadrants positive. Both ends of range will be asymmetrically limited, one worse than the other. There'll generally be, well, there will be pain at one end or more at one end than the other. And if you grind the joints, this is going to reproduce that pain. So you stress those joints, not ligament stress them, but you stress the joint out. If necessary, of course, you do ligament stress them if you think there's a ligamentous problem. For biomechanical dysfunctions, the quadrants will be positive, but the patterns will be a little bit different. Your biomechanical exam has to be positive. It's usually going to be pathomechanical, in which case you're expecting that jammed infill. But it could be one of the less common dysfunctions, such as hypermobility or pericapsular hypermobility. With jam joints anyway, it will be episodic and moderate pain, and there'll be a non-functional obligate impairment. And then for referred pain, as I say, all local tests are going to be negative. Quadrant tests and shoulder and neck quadrant testing will also be positive, one or the other. Understand though that we can have 2 conditions. We can have a neck problem and a local problem. We can have referred pain at the elbow and also a local pain at the elbow. So it can interplay, but if we're looking at this being easy for us, then this is the way it would pan out. More complex situations require more thought and more examination. But I think that combining the negative differential diagnosis and the script focused hypothetic inference will help us get to the answer faster, easier, and with less bias than if we simply did script focused hypothetic. This is very true when you have areas where there's multiple causes. Groin pain, for example, could be an inguinal hernia, it could be a hip problem, it could be an SI joint problem, it could be referred from the upper spine, it could be a psoas tendonitis, psoas tear, bursitis. So what we can use the screening test for, we make a list, that's our list of differentials. We then use each screening test to rule it out. And palpation of the muscle and the bursa, if we can reach them. Quadrant testing for the hip, Fordyce test for the SI joint, and so on. Can all be used to eliminate areas, leave you 1 or maybe 2 remaining hypotheses, which you can then attack with the essential illness script and come up with the right conclusion. It's been estimated that the average richly experienced general practitioner can make the average diagnosis in about 15 seconds of the patient walking in the door, accurately. This is pattern recognition. It's interesting because once you get used to seeing people, you can actually sometimes make the diagnosis before they're even in your treatment exam room, just by the way they move and so on. So this can only be used though when you've had a rich experience. This isn't a matter of putting in the years. This is a matter of strong, genuine, reflective practice, learning from your mistakes, going back over your cases, particularly the unsuccessful ones, and trying to figure out what you could have done differently and better. This is rich experience, and this is where this stuff comes from. We all know therapists who have been around for 30 years and have learned nothing since they left school. They're still doing the same stuff. They still have the same experience with patients. They still make the same diagnosis. They still do the same treatment. They pretty much haven't progressed at all since they've left school. We all know that person. Don't be one, basically. Now, this isn't just a matter of recognizing the pattern. A lot of this is done unconsciously. Studies have shown that when pressed, the expert who uses pattern recognition will come up, or has come up during the process, with 3 differential diagnoses at least on their final diagnosis, and it's done unconsciously. They're constantly comparing other conditions with the one they're thinking about, and it's done very, very quickly. It is vulnerable to availability and confirmation bias, but this is where the person, the expert, has generally stopped learning. It's usually about the time they start to become arrogant. They know everything, they don't have to learn anything else, and now they can't be wrong. And there's a huge bias right there. Their first opinion will be their last opinion. So this is very, very strong anchoring bias. Also, you shouldn't expect somebody who's an expert with a particular condition to be able to use that expertise on another condition with which they're unfamiliar. So it's not fair to say, well, you're the expert, you tell me. If their entire career has been spent treating knees, it isn't fair to ask them about the shoulder. So this is not transferable. So most experts, though, in musculoskeletal area will have an expert knowledge of the average condition throughout the body, with a few exceptions. But as I say, this only comes with rich experience, not just putting in years, but reflective practice, strong reflective practice. This is where you're aiming for. This is where the essential illness script, the script focused hypothetic inference, is leading you. Constantly thinking about differential diagnosis, constantly thinking about the signs and symptoms of any particular condition, constantly applying that in your reasoning process. Aim for this. The diagnosis is based on the best fit for the patient's symptoms and, to a secondary extent, the patient's profile. An inferred diagnosis becomes more deductive if the premises are not erroneous, that if the subjective and objective tests are correct and there is a minimum of bias. Hence, all questions must be asked and interpreted correctly and within fairly rigid parameters, and if necessary, and it usually is, in a closed form rather than an open form. So rather than say, tell me about your pain, it may have to be, is your pain burning or aching in type? Whether you have to do this or not depends on how well your patient understood the question and how unbiased you were when you interpret it. Confirmation bias springs to mind here. It's worth saying that closed-ended questions are less prone to bias in that there's less chance of them being misunderstood and less chance of their answers being poorly interpreted by the questioner. So it's really not a bad way of doing it. And the idea that it gives the patients cues and it helps them to lie or cheat or be influenced by you really doesn't hold up. And the benefits of asking closed questions when it's necessary certainly outweighs this possibility. Anyway, tests have to be carried out correctly and interpreted correctly rather than the results meeting your expectation of what the test will be. This is again confirmation bias. Tests should not be done casually, even though your instructor may look as if he or she is doing it casually. Familiarity doesn't always breed contempt, but more often breeds competence and alacrity. If you continue being self-critical and analyse your practice, particularly the bad results, you will improve both your reasoning skill and abilities technically, and eventually master both, being able to solve familiar problems with pattern recognition, unfamiliar problems with hypothetic inference of one kind or another, and more importantly, understand when you cannot solve the problem and then be able to figure out why you couldn't solve it. At the same time, continuous practice will lead to technique mastery. As far as prognosis goes, that changes with experience. You're not handing out medications. These, for the most part, and with most people, have predictable effect, making prognosis reasonably easy. You are using physical techniques whose efficaciousness will vary more wildly with your abilities and the patient's willingness to improve than drugs do. Do not discard the placebo or nocebo effect, but eventually you will be able to prognose reasonably accurately, probably about the same time that you develop good pattern recognition. Treatments should be based on the diagnosis, and of course this should be a pathoanatomical diagnosis, appropriate treatment for the appropriate pathology aimed at the correct tissue, essentially is what we're looking at. Of course the patient's personal requirements and preferences have to come into play. For example, if you want to manipulate the patient's spine and they don't want you to manipulate their own spine, and you go ahead and do it, that's actually criminal assault. And not only is it unethical, but it's actually illegal. But if they insist on treatment that you believe will be of no benefit, you're ethically obliged either not to give the treatment or not to charge for it if you do. If they continue to insist and you can convince yourself that there is a slight chance that it might work, you need to fully explain your choice of the treatment and how you're not sure whether it's going to work or not, and then you can reasonably carry out the treatment and charge them for it. There's nothing really unethical right there. Sometimes this is what you have to do because there isn't any other option open to you. Ideally, the treatment should be based on the diagnosis, your experience with treating the diagnosis, evidence for that treatment, and the patient's individual findings, and not some evidence-based algorithm that does not take into account your experience and the individual's foibles. That is your treatment and test. Your treatment and test should be evidence informed and not evidence based. And if you're not sure of the difference between the two, take the trouble to look it up, and it is likely to change how you practice. Sometimes you're not sure what the specific diagnosis is, and you have to base the treatment reliant on symptoms and signs rather than on a specific pathology. If you are sure that it is safe to do so, then by all means try what you think is most likely to work, even if that decision is intuitive rather than fact-based. You have to do something, and providing it's safe, do what you intuit, because intuition is usually based on experience, even when you don't recognize that that's the case. Finally, both you and your patients are individuals with all of the variabilities and foibles that entails. Your mood, your patient's mood can both alter the effect of your treatments because you are not fixing a car with a car has no moods. But consider how you would feel if your mechanic who was fixing the brakes on your car had that day learned that he was dying of lung cancer. I'd be a little bit wary about driving fast, that's for sure. I have a friend who once gave me some very good advice. He said, every now and then have a hot pack day. This is where you only use hot packs. This will, you do nothing effective, but then again you do nothing adverse, unless you burn them with a hot pack, which is probably advisable not to do. But that does lead some ethical questions about charging for this, but it does let you basically have a day when you need it to do nothing at all without actually staying at home. Ethically, how reasonable is that? I don't know. Well, I do know, but it's one of those things. Also, don't get caught up on the technique treadmill. You don't need 8 different ways of manipulating the neck or the elbow. You need to have one that you do well, and you need to have at least one more that you can do when circumstances dictate that your default technique can't be used. You don't need a dozen different ways of doing the same thing. This seems to be a collectible, and it's really pointless. On the other hand, while techniques are easy and you will master them in time, reasoning is hard, and that requires practice, practice, practice. Practice will certainly let you master techniques quickly, but it may take longer to master good clinical reasoning. You should spend at least twice as much time perfecting your reasoning as you are perfecting your technique. Also, please continue to constructively self-criticize. Periodically review your cases and see what you could have done better, and understand that you learn more from your failures than from your successes. And lastly, thank you all for watching this and taking the trouble to learn more than most therapists think they need to.